Hi, I'm Chuck Hatt, Director of Research at Enbio Inc. I'm also affiliated with the Department of Radiology at Michigan, and I'm co-chair of the RSNA-KIVA Lung Densitometry Committee. I'm going to be discussing the establishment of a technical guidance document for a single COPD and lung cancer image acquisition protocol. I'd like to first briefly discuss QIW, which stands for Quantitative Imaging Biomarker Alliance. The mission of QIW is to improve the value and practicality of quantitative imaging biomarkers by reducing variability across devices, sites, patients, and time. There are a number of committees that are organized by imaging modality, and each committee works towards the development of a profile document which outlines best practices and standards. Additionally, claims about the reproducibility of biomarkers are established, which is critical for understanding if a biomarker measurement represents true changes in disease or just noise. The Small Lung Nodule Committee is committed to understanding and improving how accurately true volume changes in lung nodules can be detected in lung cancer screening CT scans, which is important for early detection. The advent of lung cancer screening has also allowed for the potential for screening of other chronic diseases, in particular COPD, due to the strong overlap between COPD and lung cancer in smokers. The Lung Densitometry Committee works on establishing claims and standards for lung density measurements, which have historically been used to quantify emphysema and gas trapping phenotypes of COPD. In spring 2020, the Small Lung Nodule and Lung Densitometry Committees got together to write a guidance document on optimal protocols for quantitative assessment of COVID. Not much was known yet about imaging QCT for COVID. We knew that CT imaging was not commonly used in the US due to concerns about contamination and the availability of PCR testing. It was also known that COVID patients often had severe airspace disease and alterations in pulmonary vasculature, but it was not yet clear the best way to measure the extent and severity of disease, nor how well the biomarkers predicted outcomes. The recommendations in this document were for the most part based on the deep experience of the QIBA committee members in quantitative imaging of lung cancer and COPD. One of the first studies to investigate quantitative CT for COVID was by Columbia et al. Out of Italy, where CT was utilized during the first wave of the pandemic. This study defined well-aerated lung as the percentage of lungs with pixel values between -950 and -700 Hounsfield units, and showed that a lower percentage of well-aerated lung was associated with ICU admittance and death. An important aspect of this study was that optimal protocols for quantitative imaging were used, and a detailed CT protocol was outlined in the publication. Inspired by that study, we were able to replicate similar results in a completely different cohort using a slightly different HU threshold corresponding to more severe airspace disease. This was in contrast to many other studies on the use of imaging for diagnosis and severity assessment of COVID, most of which were published under the guise of AI. A review article in Nature Machine Intelligence looked at 2,212 studies utilizing AI for image-based COVID assessment and found that not a single study in their search produced an algorithm that was ready for clinical deployment. A common reason for this was poor quality data sets, which often lacked the metadata or standardization or were biased. An editorial in Radiology titled Artificial Intelligence of COVID-19 Imaging, a Hammer in Search of a Nail, pointed out that it's time to move beyond studies showing that AI can detect opacities at CT or chest radiography. This is now well established. So in other words, hey, we can detect and quantify features on an image. So what do we do with that? What is the use case? Going back to the topic of also screening for COPD during lung cancer screening, what we learned from the process of writing a guidance document for COVID imaging can be applied to the document for combined lung cancer and COPD image-based quantification. We already know that undiagnosed COPD exists within the lung cancer screening cohort. I'd like to highlight this recent paper, which looked at radiologist assessment of emphysema in 52,726 subjects that were undergoing lung cancer screening from 2003 to 2016 as part of ILCAP. Emphysema was identified on 23.8% of these scans, 76.5% of which had no prior COPD diagnosis. Now we need to establish that quantitative assessment can be used to screen for COPD. To do this, we need to standardize how we measure emphysema quantitatively in a lung cancer screening setting, and we need concrete examples of how screening for COPD can add value to lung cancer screening programs. One example use case is to use quantitative imaging to aid in smoking cessation. We developed this report as part of a smoking cessation clinical trial in collaboration with the University of Michigan, University of Minnesota, and health partners. It is based on the health belief model for improving the likelihood of adopting a behavior, in this case, quitting smoking. In this personalized report, low-density areas on a patient's lungs, as detected using automated software, are displayed on the report, and their percent low attenuation area is compared to results from the NLST study. The benefits of quitting and a helpline are then displayed on the bottom of the page. So we had originally designed the report to include a personalized cancer risk assessment based on lung density measurements, gender, and age. But initial results did not reveal a strong association between quantitative lung density and lung cancer. We looked at the literature and found a meta-analysis that concluded that there was no significant relationship between lung density and lung cancer, even though it found a strong association between visually detected emphysema and lung cancer. This was a very surprising result. We hypothesized that protocol standardization was the reason for this. So we performed our own analysis and published this result last year, showing that indeed there actually is an association between quantitative assessment of lung density and lung cancer diagnosis in the NLST. But this relationship was only significant if we filtered out scans that were reconstructed with very sharp kernels or very large slice thicknesses. Additionally, we pre-processed these low-dose scans with a noise reduction filter that harmonized them to be more similar to standard dose scans. This was a follow-up paper that investigated the effect of moving to a low-dose protocol on lung density measurements. We found that median filtering, or using iterative reconstructions for low-dose scans, resulted in lung density measurements that were unbiased compared to the measurements using a standard dose technique. We also showed that the ability to predict the presence of obstructive disease or future exacerbations was not diminished when using a low-dose protocol. This study showed the importance of scan harmonization, as well as the non-inferiority of low-dose scans for COPD screening. Similar to our results in the NLST, another study also looked at image processing techniques for scan normalization in a lung cancer screening setting. In particular, they demonstrated that a kernel normalization technique combined with slice thickness normalization significantly improved the ability of quantitative lung density measurements to predict all-cause and lung cancer mortality in a lung cancer screening cohort. I now wanted to show a few examples of how similar COPD biomarkers are currently being used clinically. This study out of Stanford looked at how parametric response mapping, another lung densitometry method, could be used to aid in the diagnosis of bronchiolitis obliterans syndrome. They showed that visual reads of inspiratory and expiratory scans compared to just inspiratory scans improved the sensitivity, but decreased the specificity of BOS diagnosis. However, when also viewing the PRM 3D overlay showing emphysema and air trapping, which is shown in this figure, in addition to the CT scans, the best combination of sensitivity and specificity was achieved. They also showed that a quantitatively measured air trapping score greater than 28% was similar to CT visual reads in terms of area under the curve for BOS diagnosis. Here we have two similar reports from different vendors that show quantitative imaging metrics for patient qualification for bronchoscopic lung volume reduction procedures. During these procedures, one-way valves are implanted in airways that ventilate highly diseased regions of the lungs, which causes those regions to collapse, resulting in improved lung function and quality of life. However, patients who have homogeneous emphysema and/or incomplete pulmonary fissures tend to not respond to treatment. Because inclusion in the original clinical trial evaluating the valves required these conditions to be met, they are also required for the intervention to be conducted. The new biomarker here is the fissure completeness score, which has not been studied nearly as much as lung density for emphysema quantification. But because this automated biomarker is critical for these procedures to scale, it has been rapidly adopted. This is not without its own challenges related to protocol standardization. For example, Embio provides the software that is used for Olympus's Select CT report. At 124 different sites using this software, we continually have to monitor the CT protocol parameters that are being used, and we have counted 78 different preferred reconstruction kernels used prior to protocol correction. Many clinicians simply aren't aware that correct reconstruction parameters are important for quantitative imaging, but are receptive to changing protocols and being provided educational materials. Other sites cannot change their imaging protocols for bureaucratic reasons. Technical guidance documents are critical to remedying these issues. So Before I end, I'd like to pose a few questions to the panelists. First, how can we accommodate radiologist preference and scanning parameters while maintaining standards for quantitative protocol requirements? What are the clinical application targets of a combined CT image acquisition protocol for COPD and lung cancer? What studies are going to be necessary to demonstrate effectiveness of a combined protocol? And how do we move beyond statistically significant associations between biomarkers and disease and demonstrate concrete examples of how the biomarkers can be used clinically? Do we have enough data to support the role and impact of doing expiratory imaging in lung cancer screening? And what is the best way to disseminate and achieve acceptance of such a document? Thank you.